A very good evening to all the respected viewers who have joined us for this very special, on this very special day for a very special webinar. It is truly a path-breaking webinar on cardiopulmonary and cerebral resuscitation, which is being conducted by the Chest Council of India, where we will be talking about the nitty-gritty of cardiopulmonary respiration, cardiopulmonary resuscitation, its technical aspects, and also its practical applications. I would like to thank respected Dr. N.H. Krishna sir, Narayan Pradeepa sir, Ashish Dubey sir, Anil Maske sir, our webinar backbone team of CVK sir, Shivani ma'am, Kirat ma'am, and Atri sir for giving this opportunity to all of us to become a part of this. I am Dr. Ravi Dosi from Indore, and I am joined by a panel of elite faculty today. First of all, I have great pride in introducing Dr. Subodh Chaturvedi sir, who prides in christening his own name as Clinical Guruji, because sir has a huge fond following and he educates a lot of people through this, and he's a very seasoned CPR instructor. We have Dr. Sukhram, who is a surgeon from the Medanta team. We have Dr. Pawan Gupta sir from Delhi VP Chest Institute. We have my dear senior Dr. Hirennappa Udnur from Bangalore, who is a very renowned pulmonologist over there, and we have young blood in the form of Dr. Amal Johnson, who is joining in from Chennai. Now, CPCR has a very long history, starting from way back in 1530 when bellows were used to 1960 when the Resusci NA, the first mannequin, came to exist. There to 2024, it has evolved tremendous. And CPR, what is CPR? A group of interventions performed to provide oxygen and circulation to a body which is arrested cardiacally. All of us might be surprised to know that there is a World Restart Day, which was hardly 20 days ago on October 16. And the sole purpose is for raising CPR awareness. That is very important. Why? Because CPR can be conducted by lay people. They can give cardiac massage in an effective way, and we'll be able to save a lot of lives if we are able to educate the masses along with our paramedical and doctor staff to do this very correctly. It is told that CPR can save up to 2 lakh lives per year if done properly. So let's begin our very interesting discussion today. And I would we have two very good presentations. Today, really, I am very proud to moderate this session, very lucky, because it's a very different sort of way that we'll be dealing with this topic. There are very good talks by Dr. Amal Johnson and Dr. Subodh Chaturvedi. I would like to hand it over to Dr. Amal for giving his deliberation on cardiopulmonary cerebral resuscitation. Over to you, Amal.
Good evening, everyone. I am Dr. Amal Johnson. Sincere thanks to CCI for providing me this opportunity to speak on CPR today. And sincere thanks to Ravi sir for the kind words of introduction. So I will be doing a small presentation on American Heart Association guidelines on cardiopulmonary resuscitation. So cardiopulmonary resuscitation is a life-saving emergency procedure that combines chest compression along with rescue breathing to restart a patient's heartbeat as well as breathing. So the chance of survival in a cardiac arrest patient, in fact, doubles and sometimes triples when the bystanders take action and immediately provide a cardiopulmonary resuscitation. For this presentation scope, we will be taking only the adult BLS and the advanced cardiac life support. So the new changes in 2020 guidelines some are mentioned. So American Heart Association, there is a chain of events with a special mention of patient recovery, early usage of AED in shockable rhythms, and early use of epinephrine in patient having non-shockable rhythm, and opioid overdose emergency algorithm has been added now. There is a special mention about post-cardiac arrest management, targeted temperature management, and neuroprognostication and recovery survivorship plan. So, according to American Heart Association chain of events, starting with early recognition and prevention activation of emergency response, providing a high quality CPR, defibrillator, and post cardiac arrest care, and a mention on post cardiac arrest recovery as well. And outside the hospital, if you take again activation of emergency response, providing a high quality CPR, defibrillation, advanced resuscitation, post cardiac arrest management, and then recovery. So basic life support, this is the foundation of saving life after a cardiac arrest, which will include skills to perform a high quality cardiopulmonary resuscitation, usage of AED wherever required, and the patient is having an obstructed valve, means we have to manage it. So the objective is not to manage the patient, treat the patient, but to buy some time until the emergency medical team arrives. So first we have to verify the scene whether it is completely safe, and we have to see the patient and we have to assess for his response. We have to manage and see whether there is any nearby help available. We have to activate emergency medical response team via a mobile device if it's possible. We have to see whether an automated external defibrillator is available nearby, and we have to see whether the patient is having a normal breathing and if the pulse is being felt. If there is a normal breathing, the pulse is we are able to feel, then we have to monitor until the emergency team arrives. The patient is not having a normal breathing, but the pulse is felt, we have to start providing rescue breathing. We have to provide 1 breath every 6 seconds or 10 breaths per minute. We have to manage, we have to see whether this patient is having pulse every 2 minutes, and if there is no pulse, we have to begin the CPR. So in cardiopulmonary resuscitation, then we have to provide 30 compressions and 2 breaths. And we have to see whether the patient is having a shockable rhythm or not after connecting AED. If it is a shockable rhythm, then they will provide 1 shock and we have to resume the CPR again. If the patient is having a non-shockable rhythm, then we have to resume the CPR. So I will play a small video which will provide the steps of CPR to the audience.
Hello. In this health sketch, we want to talk to you about CPR, which stands for cardiopulmonary resuscitation. We use CPR when someone has collapsed and is not breathing because it can keep people alive until emergency services arrive. Learning these simple life-saving skills is as easy as ABC. All you have to remember is the doctor's ABC.
This is a small mnemonic.
D is for danger.
Audience
First, look around carefully to make sure the area is safe for yourself and others before approaching. R is for response. Shake them gently by the shoulders and ask them loudly, "Are you all right?" If there is no response, you need to. S. Shout for help, as any assistance will be helpful. A is for airway. Gently tilt the head back like this to open up the airway. B is for breathing. Look, listen, and feel for signs of normal breathing. Look for normal chest movements. Listen for normal breathing sounds. And try to feel their breath against your face. Do this for no more than 10 seconds. If there is no sign of breathing, or if they are breathing in an unusual, noisy way, we need to start CPR. First, make sure that an ambulance is on its way. If you have someone with you, ask them to make the call. Putting the phone on speaker mode is useful as the ambulance service can talk you through the steps. C is for circulation. Circulation means the flow of blood around the body, and when the heart stops pumping, we need to take over this role by pushing down hard and fast on the chest. Start by placing the heel of one hand at the center of the person's chest and interlock your fingers like this. With arms straightened, press down hard and fast, letting the chest come back up fully each time. Fast means around 2 times every second. And hard means that the chest needs to go down by about 5 centimeters. This might sound a lot, but you do need to push hard for it to be effective. If you have been trained, you can give 2 rescue breaths after every 30 compressions, as this helps provide some oxygen. However, if you have not been trained or are not comfortable, just keep going with hands-only continuous chest compressions. If someone else is with you, swap over if you begin to feel tired, and don't stop until either a health professional takes over or the person is definitely breathing normally. Sometimes we can add another step. D. D is for defibrillation, which is about delivering a shock to restart the heartbeat. Some public areas and workplaces have an easy-to-use defibrillator on site called an automatic external defibrillator, or AED. Automatic means that it is the machine that decides what to do, so you can't go wrong, and it even talks you through the steps. If there is no AED available, keep going with CPR until the ambulance arrives. That's it.
So, how to provide a high-quality CPR to the patient? According to the American Heart Association, the compression has to be 100 to 120 compression per minute with a 5 centimeter or a 2-inch proper depth, and minimizing interruption between the compression and ensure that the proper hand placement is there in the center of the chest. Avoid leaning on the victim between the compression, and you have to as much as possible avoid using excessive ventilation. Only 2 breaths per 30 compressions. So, like in the previous video we saw, we just have to take open the device, apply the electrodes, switch on the machine. It will tell whether the patient is having a shockable rhythm or not. And if he is having a shockable rhythm, it will provide one shock, after which we can continue the CPR. So now the stress is on more on compression than on performing and ABC. Now the consensus is on compression, airway, and breathing. So, in case you are thinking the patient might have COVID, or you want to follow the precaution, just cover the patient's face with the mask and your face with the mask. You can perform only cardiopulmonary resuscitation and then call for help, along with performing an automated external defibrillator wherever available. And after doing a BLS, then we have to start this patient on oxygen support and then monitor. If he is having a shockable rhythm, again we have to provide 1 dose of shock and then continue to give the CPR. We have to see whether the patient is having an IV access. If IV access is facilitated, we have to provide this patient one dose of epinephrine and continue it for every 3 to 5 minutes. We can administer amiodarone and one dose of lidocaine. He is having a refractory VF for a paroxysmal ventricular tachycardia. Consider an advanced airway like a supraglottic airway, along with managing the patient with the capnography. And we have to manage the reversible causes if there is any like hypovolemia, hypoxia, acidosis, hyperkalemia, hypothermia, tension pneumothorax, a cardiac tamponade, and a coronary or a pulmonary thrombosis. So the stress is now on early use of epinephrine in patients having non-shockable rhythms. So after the ROSC is obtained, then we have to manage the patient with an endotracheal tube. After connecting the endotracheal tube, we have to target a saturation of 92 to 98% and a PaCO2 of 35 to 45, along with maintaining the blood pressure of greater than 90, greater than 65. Perform a 12-lead ECG and see whether the patient is having a heart attack, a STEMI, or an unstable cardiogenic shock. And if he is able to follow the commands, we have to continue with the critical care management. If he is not able to follow the commands, then we can follow PTM or perform a brain CT or perform EEG to see whether the patient is able to come out of the cardiac arrest. Then we have to neuroprognosticate the patient. In the first 24 hours, we can do only a CT and C. Followed by that, we can do an MRI. Then bilaterally, the patient is having an absent N20 somatosensory evoked potential. It is an indicator of a poor outcome. He is having again myoclonus. That is also a poor outcome. The neuron specific enolase marker is very much increased. That is also indicator of a poor outcome after the cardiac arrest. So after the cardiac arrest, CPR, BLS, ACLS, everything is over, then the patient is having a ultra short term, medium term, and a long term outcome. We have to follow up the patient in terms of physical recovery and then manage the along with that patient is having a psychological problem also. So thank you very much. So with this, I hand over the session to Dr. Subodh Chaturvedi for his comments. Thank you very much.
Thank you very much, Dr. Johnson. It was a wonderful lecture. Let's move on to the application of those principles now. Let's go to an ICU and see a patient. Oh, this patient is arresting. Hey, are you okay? Are you all right? Help, somebody bring a defibrillator and call the code blue. Oh, this patient is in PEA, I guess. There is bradycardia and no pulse, no saturation tracing. Let's start CPR and maybe give some epinephrine. And he doesn't require shock, keep giving epinephrine and CPR. 20 minutes the CPR goes as per ACLS protocols, but the patient doesn't survive. Why? Not every patient survives. We know the success rate of CPRs even in ICUs are not great. They are like 4, 5, 6%. What if somebody had paid attention to the monitor or the screen of the ventilator before jumping onto ACLS protocols? I would like to thank CCI, Dr. Ravi Dosi, CVK sir, for inviting me for this small talk. I will talk beyond ACLS. I'll try to put my point that ACLS is good, but it is not good everywhere. We might still need to use our own intelligence, our own brains, rather than following a strict protocol. Americans have a tendency to make everything guideline based and system based. They want to make every system idiot proof, and they are not wrong in that. But ACLS was primarily meant for the people, the paramedics who are working on ground, who have to revive a patient who has died most likely because of a coronary event. But this place is different. This is a respiratory ICU. Here, your protocols or your so-called things don't work exactly. A respiratory ICU is very different from a routine roadside coronary event or maybe a cardiac ICU. Your causes of arrests are totally different. So today in this lecture, I'll try to focus on those parts only. In respiratory ICU, the arrests are primarily not because of a coronary event, but they start with either hypoxia or hypercarbia. And maybe air trapping and auto PEEP can be a big issue in killing those patients. So if we go strictly by protocol, yes, they include 5 H's and 5 T's, the tamponades and all those things, but they came later in the picture when you have realized that the patient is not surviving. Then you think of other causes, what could have caused this arrest. What if we, as doctors, think of the cause first and then jump to revive? Maybe change the protocols a little, maybe change the systems a little. So I'm not advocating to shun off or to remove ACLS from our armamentarium. All I'm suggesting is that maybe we can look for some other things. Maybe during assessment, if somebody just looks at the ventilator tracings and he sees auto PEEP, he can just disconnect the circuit and wait for 20 seconds, and that might save the patient instead of going all gaga with CPR. Or maybe we can primarily check for ventilator circuit disconnections as causes of hypoxia. Or maybe we can look for tension pneumothoraces during assessment. So we can assess, are you okay, all right, everything, he has pulse or not, and everything is fine. But maybe we can add these things to our assessment so that we can recognize the causes that occur in our ICUs early and then jump on reviving the patient. Similarly, maybe we can change a few things during CPR also, because most of our patients are dying because of respiratory causes. They are either COPD patients or maybe status asthmaticus arrests. So maybe we can change the things a little. Of course, they are not meant for nursing staff and everybody. But if somebody of your caliber, if a chest physician is there, then maybe he can guide to maybe use a little slower compression rate rather than going all 100, 120. Maybe give some more time for elastic recoil. Maybe give some more time for exhalation. Maybe you can stay up for a little longer. Maybe when you are ventilating, the person can assess the resistance in the bag. What if a tension pneumothorax is developing? How is the spasm resolving or not? Because the primary causes might be inside the lungs and not the heart. The heart is arresting because of the lungs. So maybe we can change a few things in our system. Maybe we can stop compressions sometimes to allow full exhalations. COPD patients, when they die, the CPR might be a little different. We might not go full 2.4 inches depths. Some of these patients, they have like barrel chests and everything, so they might not need full depth. Or maybe we can, again, like I said, we can focus on achieving good recoil. We can watch for increased resistance, as I talked earlier, and we can consider using ETCO2 to guide effectiveness. That ACLS also says, but in ICUs, often we have ETCO2 monitors, and we can use ETCO2 to guide the efforts rather than pulse or anything else. We can change in monitoring. We have discussed most of the things. What else we can do is maybe we can feel for chest wall compliance changes. How is it working? We can watch ventilator waveforms. Somebody can be assigned, like a recorder, somebody can be assigned to watch for ventilator waveforms. We can do a few different things in medications apart from these epinephrine and lidocaine and everything. We can do some other things. Maybe we can plan for bronchodilators through ETT. Maybe we can think of steroids. We can think of magnesium if it is a status arrest. So I'm not saying that ACLS is gone for good. But just remember one thing, ACLS is good, the protocols is good, everything is fine, but we are experts, we are respiratory physicians, we are chest specialists. So we should remember that it is a guideline designed for the average arrest. Your patients are not average. Think beyond the protocol. Before I leave, I'll leave you with the image of the ventilator settings during CPR. I'll just come out from the screen. You can take a screenshot. This I found in probably a chest paper. These are very good. You can just take a screenshot. And thank you very much again for inviting me.
Thank you, Dr. Subodh, sir, and Dr. Amal. Actually, I felt as if I have done both the UG course as well as a PG course in ACLS just now, because while Dr. Johnson about the algorithms, Dr. Subodh really gave a very thought-provoking lecture as to what more as specialists we need to realize and do while managing our specialized cases. So now to begin with this panel discussion, I would like to call upon Dr. Hirennappa, and I would just like you most common settings that we see is in cardiac arrest might be a case of ventricular fibrillation. So how do we go about that case of ventricular fibrillation, sir?
If any ventricular fibrillation, when there is a shock, when there is a CPR, we have to go and see, and the ECG is being connected, we find the VF. That is the most preventable cause because it's a shockable. So shockable rhythms or non-shockable rhythm is the one thing which we look at, and we call for emergency help first, and high quality CPR, as Dr. Amal Johnson has told, that is a must. And most of the time, the saturation on the monitor should look 93. Sometimes if the pulse and all is not good, then we may not see that kind of monitor, these kind of systems, and connect the proper ECG leads and have a shockable rhythm. Prepare, analyze the rhythm first. Take your time. Even in emergency, you have time. Even in emergency, you have some amount of time. Otherwise, if the no time is given, you can't save the patient. So it's called an hyper urgent emergent situations. Prepare, have a proper lead. Take one person has to take the lead and give a proper shock. Do a CPR for 2 minutes. Repeat these cycles of 5 to 7 minutes, and you can continue up to 20-25 minutes, as Dr. Subodh said, and you can go up to 40. And if sometimes advanced care facilities are there, and you have an intensivist on ground, we have a cardiologist on ground. Sometimes we save a lot of patients with the VF by giving a shock. These are VFs are rhythms have become people who are working in ICU with a continuous monitor. We see more frequently in hospital, out of the hospital shock, in hospital shocks who come in a cardiac arrest. This is the most easy things where shocks should be given. The rhythm, seeing the rhythm is important.
Right. Very well said. And your point that you also have time in emergency comes with practice and being very particular about the protocols. So your point is very well taken. Now from Bangalore, I would like to shift to Delhi and ask dear Pawan sir that suppose you get a case which is just the reverse, a case of asystole. And how do you feel that we would like to go about it? Please unmute yourself.
So basically, the asystole is the rhythm, which is most of the time it is a terminal event in the case of the cardiac arrest, and most of the time we declare the patients when we get the asystole rhythm. But because we are not left with many options in the asystole, but we have to perform our initial assessment. We'll have to perform we have to continue the high quality CPR. Along with this, we have to maintain the oxygen saturation more than 94%. And if the patient is having the cardiac, the heart rhythm, which is consistent with the asystole, then in that case, there is no chances for any shockable rhythm. So in that conditions, we need to give the epinephrine, because epinephrine we can give 1 mg as soon as possible. And we can repeat it every 3 to 5 minutes. After 2 minutes of the CPR, we have to recheck the rhythm. And if fortunately we get the rhythm of other than the asystole like VF or VT, then we may have some better chance of the survival of the patients, because in that case we have the many other drugs like amiodarone or lidocaine which we can give, or also it is shockable rhythm. So other than this, we have to evaluate and treat the underlying cause. And if we get the spontaneous circulations, then we have to switch the protocol to the post-cardiac arrest. So after getting the asystole, we have only one medicine, that is epinephrine, which we can repeat every 3 to 5 minutes. Every 3 to 5 minutes, 1 mg. That's all.
Right, quite right. So I think initially we have gone for both VF and asystole management. But Dr. Amal, I would like to bring you back after your very nice and extensive lecture. Dr. Amal, can you hear me?
Yes, sir. I am.
Would really like to know from you what are the common medications used in this particular adult cardiac arrest algorithm.
Starting with epinephrine, sir. So, like Dr. Pawan sir told, we have to use epinephrine once in 5 minutes. Once in 3 to 5 minutes, we have to consider use. The proper dose is 1 mg. That is 10 ml of 1:10,000. That will be the dose. So we have to, as much as possible, and consider use of epinephrine in patients. And then the second medication would be considering use of amiodarone. Amiodarone, we have to start with 300 milligram bolus, and then the second dose can be 150 mg. Third medication would be starting this patient who is having a ventricular tachycardia would be considering lignocaine. So 0.75 mg to 1.5 mg per kg, as a start dose, and then 0.5 mg to 0.75 mg as a second dose.
I agree here, but at that time, 0.5 mg, 0.75 mg, you can't multiply. It becomes a bit difficult. You have to be as cool as Dr. Hirennappa, who finds time in emergency. Still,
it should be actually a preloaded things. Emergency cart has to be ready. You don't. That's for our explanation. Most of the people who are trained in ICU and they know exactly dose. The adrenaline never has to be bolus. It has to be preloaded, and this has to be used. They are life saving, sometimes life killing also.
Right. Very, very rightly said that these drugs are very, very, drugs with low therapeutic index. So we have to be very careful with them. So now one very important point that all of my panelists up till now has raised is about CPR quality. So whom better than our Guruji to talk to us about how to maintain this CPR quality? What is this, sir?
Sir, everybody does CPR. I mean, right from your GNM nurse to your senior consultant, everybody knows CPR. But then in hospital arrest, they survive better than your roadside arrest. Why? Because quality of CPR matters. So there are like 4 or 5 things which should be which should be remembered while doing a CPR. First, the depth should be adequate. You are compressing your sternum against the vertebral column. You are not pressing heart or ribs. It should be good quality CPR, at least 2 to 2.5, approximately 2 inches. You should compress. Secondly, the speed matters. Some people do it very fast. They are like too enthusiastic. 1, 2, 3, 4, 5, 6, 7, 8. Some people do it very slowly. The speed should be approximately 100 to 120. You should have a beat ringing in your head. Ki 1, 2, 3, 4, 5. That's it. Thirdly, many of the people I have seen, what they do is ki they go down, but they don't come up as much. So elastic recoil has to be allowed. You have to let the heart fill with the coming blood and then push it again. And lastly, you have to minimize interruptions. You should not be like कि okay CPR कर लिया, अब तू आजा, तब तक मैं रुका हूँ. You cannot do that. You have to minimize interruption. One person leaves and other person jumps. These are like quality maintaining for CPR.
Quality maintaining, and even like what is more important is apart from the quality CPR, sir, एयरवे मैनेजमेंट को उन्होंने पीछे कर दिया, मतलब कंप्रेशन एयरवे ब्रीदिंग कर दिया.
Exactly.
बस टॉक अबाउट एडवांस एयरवे मैनेजमेंट थोड़ा बताइए सर.
Right. So first and foremost, see, respiratory ICU, it can be different. Many of the patient might be already on ventilator, but in general, if we say compressions are more important than ventilation. So do not wait for a tube to come and then we will start CPR. First and foremost, keep doing CPR. Don't interrupt it for anything. Then many of the people, see, we are anesthesiologists, we can intubate a patient in like 20 seconds. But then if you are finding it difficult to intubate, don't intubate, just keep it on a simple umbu and mask and keep ventilating. Even if you want to intubate, maybe an iGel or an LMA is a better thing than intubating, because intubating takes like good 20, 30, 40 seconds, and then to like during the CPR, intubation is very difficult. So unless until you are very sure and everything is fine, don't go for intubation. Advanced airway management, just stick to basics, just keep umbu and mask.
Thank you. Very important even for the lay people who are promoted to do a cardiac massage continuously. But suppose in a setting where defibrillators are available. So Dr. Johnson, defibrillation, just tell us how can defibrillation be done and what is this double sequence defibrillation we hear about?
Previously, there was some consensus regarding this, sir, whether we can provide at a time two fibrillator and whether it will benefit the patient or not. But in the 2020 guidelines, they are told that the benefit is not great and the problems are more. So now it is not being recommended to use. Only one machine is
one machine. So you go for your defibrillation as per the rhythm which is available.
Exactly.
So now everything is done. We have done a quality CPR. We have managed the airway, and Dr. Johnson has defibrillated, and voila, the patient has return of spontaneous circulation. So Dr. Hirennappa, now how to manage this return of spontaneous circulation?
One thing is sure, it doesn't happen like a rowdy daughter scene. What we see a Jintata. When we have a cardiac arrest, he does the jintata, titata, and he gets up. That doesn't happen in real life. Okay, it rarely happens. Okay, so once resuscitation of spontaneous circulation, when you do a cardiac compression, the CAB, what Dr. Subodh has said, when the circulation sets in, the circulation has to complete the loop, the arterial to venous phase. It has, if that is achieved, then the rhythm has come back, ECG rhythm has come back, and circulation has come down. Then we have got that right, means then that's the time we need to. So while doing a compression, we don't intubate. So ventilation is a one good thing. See, ventilation, we need less. Circulation, we need more because it beats faster. Lungs, we breathe at 20. Heart, we breathe at 60 to 70. So when ventilation has to be achieved, you get a proper timing, get it, don't do esophageal intubation and this thing, you need a proper person in just head tilt and proper airway management, advanced airway, see the ETCO2, that's the best way. Sometimes we can auscultate, bilateral bedside, we need assistance. good ventilation. Don't hyperventilate. Just because you have intubated, you don't have to pump in. We just don't require that. We just need to wash out. Ventilation means washing out the CO2, which a basic minimum you need to get to 25 to 30. We should not have a hypercarbia. So don't hyperventilation. So once you achieve that, so you need some, see, when there is a hypothermia, all your metabolic systems will be calmed down. So hypothermia is needed. There is something called as targeted temperature. There is a hypothermia. We need some kind of systems are there. We would have seen, it has evolved when we are doing a PG. We were more into emergency, more into ICU earlier. Now we are seeing it more in OPD. Sometimes we see in more in interventions place or endoscopy or bronchoscopy suits.
Right.
So what exactly we have to do is, once you achieve that, treatable causes, hypovolemia, need a good volume correction is required after achieving the ventilation, connecting ABGs and getting arterial lines and all. It may take some time, but getting a good wide bore needle and preparation for central lines, giving a good fluids and maintaining the temperature, and there is some pump like systems will come. And we see some blower like system is there in hypothermia to create the hypothermia that is there in the system. And people who are being continuously doing in ICU in COVID, no, people have given with ventilators also, patients have not survived with unskilled systems. If the patients are seen and patients are being continuously there in the ICU for long duration, those patients definitely survived in those ICUs. So if you contain a hypothermia, 12 lead ECGs are being put, hypothermias are, and know the cause. Once you achieved that, once that is completed, if it is a cardiogenic shock, inotrope, hypovolemic, you need a blood transfusion, blood loss is there, or if it is a cardiogenic, we need an IABP facility, cardiac intervention, cardiac reperfusion. That's the where it has to go ahead. And 4H and 4Ts, whatever he was maintaining, hypokalemia, hyperthermia, hypo-H, and cardiac tamponade, tension, pneumothorax, and these things, patient should not die of respiratory. Respiratory gives us time. Cardiac doesn't give us the time. If respiratory gives us time, cardiac tamponades. You have seen cardiac tamponade. We need a cath lab. Earlier, they used to put a MBBS doctor can put a cardiac cath test and drain the pericardial effusions. Now we need a cath lab facility. Nobody will take a risk, and we need a medical legal system surrounded with a cath lab, and we don't need that. If a good cardiologist is there, he can guide you well in cardiac tamponades and ICD, wide bore needles. All these treatable causes are important to go. Once you achieve a ROS, there are many things, then you get a time to think, what are the causes? If you are able to get the cause and we get fix it before a neuro protection is important. After, if there is a hypoxic encephalopathy, there is no tool in the world that you detect hypoxic encephalopathy has happened. Even the MRI PET, nothing will tell. Brain looks normal structurally. So how much you just have to give time. So if the neurological outcome is good, you can try eternally in a young patient for a respiratory and other things. You should look out the cause and achieve the success and save the lives.
Right. But any word about soda bicarb? There is a question from Dr. Mukesh Shah that is there.
Sir, there are treatable causes are there. Treatable causes, if there is a bicarbonate, if it is a sepsis, lactates are very high. Soda bicarbonate, pH 6.9 is life-threatening. Sometimes we see a 6.6. Sometimes we need a dialysis also to get it acids removed. Soda bicarbonate can be given because acidotic milieu is not good for inotropes are resistant to get the BP up. So renals will, it is a vicious cycle. So you give a bicarbonate such that we need some time to do a particular interventions, proper fluids. Soda bicarbonate to maintain means 6.9 is not, it's very bad. So if you get it to around 7.2, 7.3, we just get a time. Sometimes in 6.5, we get arrest, hyperkalemia, all those things will happen. So soda bicarbonates in a way how it has to be think. So it has to be followed by some other interventions.
Right.
So it helps us to improve the acidotic milieu.
Right. Very right. Now you, Dr. Hirennappa sir, talked about targeted temperature management. So I would call in a doctor who is working in one of the most premier facilities of the country, whomsoever than Dr. Sukhram, to talk about targeted temperature management. Sir, how do we go about this?
Yes, sir. Obviously, if we are talking about the targeted temperature management, the patient is once the spontaneous return of circulation is there, and we are planning for how we can have the better outcome. So I was looking at the guidelines which says it's like 2015 and 2023 AHA guideline. In 2015, they said the hypothermia has better outcome than the normothermia, but which is not true as of now in 2023. They said ki normothermia or hypothermia both may have, because in the earlier they used to say set the temperature of 32, 33, and which gives the better outcome than the 37.5, something like that. But currently, what is being recommended is something temperature between 32 to 37.5 is the target. But at any cost, they say is the temperature more than 37.5 should be avoided or undesirable, because that will give the bad outcome. Now there are so many methods with which is being used, like sir was saying that the having the bowler or something, but mostly in commonly being used with the ice packs which controls it, or by using the gel pads, or putting catheter inside and using catheter based technology, or maybe with the catheter inside and using the cold infusion, cold saline infusion, something like that. But by and large, what people are, I mean, it's being suggested that we should be not having pyrexia, because that can be having the undesirable outcome. So protection for with the regulated temperature between 32 to 37 point is a good thing.
Right, sir. So that means it's not an advanced setup which is required. It's basic ice and not letting hyperpyrexia happen, which is important. So now there is one very important thing that Dr. Hirennappa told is, once you don't know the neurology, what is the neuroprognostication? So Dr. Subodh, sir, I would like to ask you, what there is this very complicated term, multimodal neuroprognostication. So sir, थोड़ा सा कुछ इसको simplify करिए ना हमारे लिए.
ठीक है सर, ठीक है सर. First of all, neuroprognostication. You brought back the heart. आपने CPR कर लिया, patient survived. You have got the rhythm. The patient is in ROSC, return of spontaneous circulation. But is he alive or is he brain dead? Maybe CPR went on for like 20 minutes. Is his brain fried or is his brain alive? You cannot say that right away. But we as clinicians tend to jump. Oh, nahi bach jayega, nahi bachega. No. Maybe we should wait. First of all, first we have to bring him back to normothermia. We have to wait at least 72 hours before making any kind of prognostication कि हाँ होगा, बचेगा कि नहीं बचेगा, या कि brain आएगा कि नहीं आएगा. We should not be in a hurry. And then there is no single thing कि doll's eye movement है तो ठीक है, या नहीं है तो ठीक है, corneal reflex है कि चला गया. No, not like that. We have to wait. We have to involve multiple things. We have to look like we can do like EEG, we can do like SSEP, we can do CT, MRI, and there should be at least 2 to 3 modalities. If they confirm, then we have to prognosticate. So that is why it is multimodal prognostication. We cannot prognosticate by simply saying this कि नहीं ये reflexes चले गए हैं तो कुछ नहीं होगा. There should be regular team discussions. There should be a team of people involved, neurologists and other people, and they should judge it by maybe blood tests, maybe clinical examination and neurological examination to prognosticate if the patient is going to make it or not. And first and foremost, you should wait at least 72 hours to declare something.
Right. So you simplified it to a great extent, sir. The difficult part is this is that period when the family is hopeful. Arey bach gaya, he got saved, and then you are asking us to wait for 72 hours. That is where the team counseling part and regular monitoring is very important. This is a very emotionally fragile period for the family, and the treating team has to deal these emotions very, very carefully and medically very correctly. Now, to the great pleasure of all you panelists, I would like to inform you that we have 1,498 logins as of now watching this webinar. So a big round of applause to all of you, and let's try to give more knowledge sharing through this very important webinar. And the most important part, I am going to ask the most important question to Dr. Pawan Gupta sir now. That Pawan sir, what are the common mistakes that we see during CPR? Please.
So this is a very important, because most of the time the mistakes which are commonly done related to the compression. So that's why it is more and more focused nowadays is being towards the compression. So most common error which is done is the inadequate compression depth. Normally it is recommended to do the compression with a depth of around 2 inch or the 5 centimeter. Similarly, the incorrect compression rate, so the recommendation is 100 to 120. So both of these, if it is not performed, decrease the effectiveness because it does not circulate the blood throughout the body. So third common mistake related to the compression is the not allowing the chest wall to recoil. So when it is not recoil, so the blood flow that decreases or it impedes the blood flow to the heart. Similarly, there are some procedure related the mistakes which are done like delayed CPR starting or initiations. So most of the time it is because the rescuer, they are not confident enough. They know that I am not so confident to start, or they are not having any help. But the thumb of rule is that start the CPR as soon as possible, right? Even if they don't know the rescue breath, but start the CPR. Similarly, the another thing which is commonly done is the interrupting compression. So interrupting compressions while giving the rescue breath or while reading the heart's rhythm. So it is recommended that don't interrupt the compression more than 10 seconds because they are directly associated with the poor neurological outcomes and poor survival. Now, there are other errors like which are the positional related errors. Position related errors like incorrect hand placement. So many times we see that when we do the CPR, our hands are not on the lower half of the sternum, but it is over the upper abdomen. So what happens that it decreases the effectiveness of the CPR. Similarly, the not tilting the airway management related like not tilting the head back. So not tilting the head back because it is very important to maintain the airway. So if we are not maintaining the airway, so giving any ventilation is a waste. So that's why it is very important to open the airway by head tilt and chin lift technique. Like Dr. Subodh also mentioned, like over inflating the lungs. So when we are giving the too rapid or too prolonged breaths, so we are doing the damage rather than doing the benefit because it may cause more air into the stomach, causing the risk of aspiration and causing the risk of further lung injury. So all these are the common errors which can be prevented by good CPR technique.
Right, very right, sir. And matlab, there are so many things, there are so many people involved in that CPR. Sometimes when you forget to say clear while giving defibrillation, some of our fellow might also get electrical injury. So we have to be very careful and remember that it is a team job going on. But tell me one thing, Dr. Pawan, करा बहुत करा आधा घंटा पौन घंटा and then the patient survives and then there is something called as a post arrest lung injury. Now what is this post arrest lung injury?
Yeah, so most of the time we are more focused on the post-arrest neurological injuries, like which is called as ischemic injuries, neurological ischemic injuries. But it is also very common. Up to 50% of the post-cardiac arrest survivor, they have the lung injury that is also known as the ALI. So the pathogenesis is very complex. It may be because of the chest trauma related to the chest compressions, maybe because of the mechanical ischemic inflammation, hypoxia. So there are multiple factors. Similarly, the ischemic reperfusion injuries. So even aspiration, that is also nowadays, it has come many papers that aspiration can be seen in up to 30 to 40% of the post-cardiac arrest survivor during CPR. So basically the pulmonary edema, now it is also known as the cardiac arrest associated pulmonary edema, TAIL, and this is generally a transient in nature. And the more common factors which are related to pulmonary edema are the left ventricular dysfunctions or ineffective chest compressions, or there is another that is a mechanical CPR. Now there is mechanical CPR we are using in some special circumstances. It is also related to the more ALI as compared to the manual CPR. Now the thing is, what are the ventilator strategies which we can follow in these patients which are having acute lung injury? So, like in ARDS, we do the lung protective mechanisms. In this also, we need to have some specific criteria for the tidal volume or the PEEP. So, tidal volume we have to keep it low, around 4 to 6 ml per body weight, and also we have to but maintain the minute ventilation. So we need to adjust the respiratory rate. Similarly, with the PEEP, we need to be PEEP of around 5 centimeter of water because too excess of PEEP may cause the further intracranial injuries or it may cause the increased intrathoracic pressures. and too low PEEP can cause the chances of atelectasis. So that's why adequate PEEP is essential. And another thing is the PEEP pad, that is blood to pressure, that is to be maintained around less than 20 or less than 25. So all these ventilator strategies need to be performed in ALI patients, which are post cardiac arrest.
Right, sir. But tell me one thing, that matlab, it's almost as if after CPR you have to manage the patient like an ARDS in some cases. 72 hours neurology, ARDS, God knows when it is going to improve. So really prolonged CPR, though my sound, reflects our dedication to save life. But ultimately it also is associated with big issues. So we have to be careful and we should know our limits. Now tell me, Dr. Pawan, are there any contraindications to CPR also?
Yeah, this is a very important thing, because only contraindication is do not resuscitate order. But in India, there is no such order which is legally documented, even though it is widely practiced in our intensive care units. So, do not resuscitate order. This is legally practiced or legally documented in the Western countries, but not in India. So to tackle this issue, the ICMR has come out in 2021 document or the statement that, and they have given the freedom to the clinicians that they can decide who is taking care of the patient, and who know the patient's condition better, whether to go with the CPR or not. And the statement is also that CPR is not to be as a default. It is a medical procedure, and it, in some special circumstances, it cannot be done depending on the clinician. So they were given some power to the clinicians for deciding whether they can continue the CPR in certain circumstances or not. Similarly, on these lines, the Indian Society of Critical Care Medicine has come up with a certain guideline for the intensivist for the DNR. They have specified that the DNR can be done in certain circumstances where resuscitation is not going to give the much prolonged and useful benefit to the victim. Like if they have the terminal illness, or if there is a, if we find the patient in the prolonged unconsciousness where it is not going to give the benefit, or medical treatment is going to be futile. So there are some criteria where there is some relaxation where we can we can go with the DNR. Other than this, there is no absolute contraindication for the CPR.
Right, very, very correctly told. So I think we, in general, we have talked about the established guidelines of American Health Association regarding cardiac arrest, and we have seen the newer modalities. But now I would like to just quickly move on to a few common case scenarios that we commonly see in this practice day in, day out. So now I would like to ask Dr. Subodh Chaturvedi sir, that suppose that we are seeing a patient of respiratory failure, and do you think that there are any special things that we should take care of if that respiratory failure patient goes into cardiac arrest?
Guidelines always say ki 30:2, 30:2 compression and ventilation ratio. But the same guidelines, when they are applied to infants, they say the ratio should be 15:2. Why? Because the infant dies mostly because of hypoxia related causes. Their compression se zyada ventilation is more important. So maybe we can extend that idea to our patients who are dying of hypoxic failure. They should be given, maybe instead of 30:2, maybe we can, I am adding a maybe, depending on the scenario, maybe we can ventilate them more and maybe with a little less compressions. That is one thing. Secondly, again, respiratory patients, maybe we should be watching for ETCO2, maybe we should be watching for air trapping, the resistance in the bag, those things become more important. So in our particular scenario, chest physicians, maybe we should focus more on ventilation and not less on compression, but more on ventilation.
Okay, so just now I would like to add one audience question of Dr. Jyoti from Bangalore, that if there is a case of sepsis with hypoxia in a patient with vanishing lung, then how can we intubate?
Again, sir?
She is asking that if it is a case of sepsis with ARDS, then how, with vanishing lung, you can't see the lung on X-ray. How are you going to intubate that patient in CPR?
During CPR, तो आपको you have to do it on umbo and mask only. If you get time to intubate, maybe if you get a rhythm and then you want to intubate, I mean, intubation is going to be the same only. How is it? How is intubation going to get changed?
Right.
I would
So
ask her to maybe clear on her question. Maybe we'll come to it again.
again, I agree with you. But now, Dr. Pawan, you matlab, what do you say if a case of bronchial asthma develops a sudden cardiac arrest? Then do we have to take some care in that CPR of that case?
Yeah, basically, the bronchial asthma main problem is the respiratory arrest and respiratory acidosis, and because of the increase in intrathoracic pressure, there is a decrease cardiac output, so leading to the cardiac arrest. So basically, we should follow the standard guideline of the BLS, ACLS, but more focus should be on the airway and as well as the ventilation in case of bronchial asthma going to cardiac arrest. Why? Because most of the bronchial asthma patients, they have the mucus secretions in their airway. So we should first clear their airways prior to start with the CPR. Also, as Dr. Subodh has mentioned, we should be very gentle while doing the CPR in this case because there is already an increase in intrathoracic pressure and autopy. And if the patient is not getting ventilated, one should rule out the chances or risk of the pneumothorax because the pneumothorax is very common in these patients. And if there is a autopy generation, patient is not getting ventilated, then there is no harm in brief disconnection from the bag mask or the ventilator while continuing with the CPR. So that to relieve the air trapping. Another thing is that while intubating these patients, we can use the largest diameter of the endotracheal tube which we have at that time present. So that to basically tackle the airway resistance. Regarding the ventilator strategies, there should be a low tidal volume, low respiratory rate, but yeah, prolonged expiratory time to give the more time to the exhalation. So all these things are some deviation from the standard guidelines, and we can do in the asthma patients.
Right. Dr. Subodh, epinephrine doses in case of asthma CPR, do we have to take care of that also or not needed?
Well, theoretically speaking, no change needed. But then again, what I'm saying is anecdotal, physiological. They are not written in guidelines as such. But think it that way. A bronchial asthma patient who is in a status asthmaticus, he is already maxing on his adrenaline. He is already in a sympathetic overdrive. He is hyperstimulated with the sympathetic drive. So adding more adrenaline to the system might actually cause arrhythmias. Also, this person is getting beta 2 stimulants also for his bronchial asthma. That might add to his arrhythmogenic potential. So maybe we can tone down the dose a little, or maybe we can modify it to a little diluted and a little lesser dose. I have heard some speakers about giving adrenaline not as boluses, but rather run a drip of epinephrine. Put epinephrine like 1 ampule in 500 of NS and keep it running rather than giving intermittent boluses every 3 minutes. Maybe a running drip can be a better idea in asthmatics. Secondly, also along with the epinephrine, maybe we can add some magnesium because that helps in bronchial asthma patients, especially if they are in arrest. That helps us an antiarrhythmic also. And obviously, during CPR, we don't need longer cycles. We need to give exhalation a little more time.
Right. Although I did take this case scenario of bronchial asthma, but I think a lot of these principles apply to almost all cases of obstructive airway diseases, more common in cases of COPD, which will land up on the ventilator much more than asthmatic cases. So point well taken. But Dr. Pawan sir is from VP Chest Institute, they are very famous for their allergy tests. Suppose somebody goes to VP कि भैया हमारा एलर्जी टेस्ट करो and skin prick testing चल रही है and suddenly somebody has a anaphylaxis and develops a sudden cardiac arrest. So Dr. Pawan, how will you give CPR to that guy?
So yeah, you're correctly, Ravi bhai, because anaphylaxis, even though it is very rare, but once in a while it may occur. So it is a multi-system basically disease, but it mainly involves the respiratory tract like in the form of laryngeal edema or bronchoconstriction and the circulatory collapse, that is vasodilatory shock. So regarding the management, we should follow the BLS and ACLS guideline, but the key is the epinephrine. So whenever we do this test, wherever it is, we should have the epinephrine ready because this is the cornerstone of the management. So epinephrine, because if the patient is not having any IV access, then IM epinephrine is good enough. It is easy to give, safer and effective also. So the dose is 0.2 to 0.5 mg, and the strength is 1:1000, and it can be repeated every 5 to 15 minutes. But if we have the IV access and patient is in the anaphylactic shock, then we need to give them the IV epinephrine in a smaller dose of 0.05 to 0.1 mg. And most of the time, these patients have the obstructive airway edema. So we need to be ready for tracheostomy, emergency tracheostomy, or emergency cricothyroidotomy. Now, regarding the IV corticosteroid, so generally we give the IV corticosteroid in these patients who are having anaphylaxis, but the studies, they are not in favor, and even outcome, they are saying that it is not good or it is similar if we don't give or give. Regarding the nailed beta agonist or giving the antihistaminics, there is no role. So only role is of the epinephrine.
Ultimately, so epinephrine is the lifesaver as far as sudden cardiac arrest, and in most of the situations are considered. But suppose we have a great masquerader in the form of pulmonary thromboembolism. So, Dr. Hirennappa, what happens if a patient of pulmonary thromboembolism, a known case of pulmonary thromboembolism, develops a sudden cardiac arrest?
See, when pulmonary embolism, it can cause a non-massive embolism. Massive embolism means there's a hypotension, RV dysfunction. So when ultimately, when there is a severe massive embolism, when there is a RV dysfunction, they can precipitate a cardiac arrest. So it's not, it's an extension of a massive pulmonary embolism. So we need to treat the pulmonary embolism correctly. So if the likelihood of a known case of pulmonary embolism means sometimes we know there is a known case of DVT is operated, we can't thrombolize post-operative setting. So we need, if it is a massive one, the risk benefit and consensus is required. If the hypotension is there in a non-post-op setting and they have a DVT and pulmonary embolism, you see a DVT, it is presumed that it is pulmonary embolism. Now we have a fast scan and we can see an inferior vena cava thrombus going on, or you can see a right pulmonary artery thrombus. And sometimes we are not able to shift him to the CTPA and all. We assume there is a hypotension. The life-saving thing that can be is the thrombolizing agent. So we just decide, we maintain the perfusion, we do as far as the guidelines to do a CPR, circulation and perfusion has to be maintained. So it depends on the scenario where we are staying. And in Baptist, in 85, 90-year-old, it doesn't have any money, and there is a hypotension. We know it is pulmonary embolism is assumed they can't do. So we didn't had that kind of tenecteplase or altiplase can be given in over, tenecteplase can be given in 20 minutes or it's IV bolus. So we need that kind of an emergency acute care medication like drug was not available because streptokinase and urokinase dose is given for longer duration. So we continued thrombolizing for 72 hours, maintained perfusion, intubation, IV fluids, mean arterial pressure is maintained. Patients have survived and got extubated. So pulmonary embolism situations, thrombolizing, now we have got an excellent thrombolytic drug. If there is no contraindication for a GI bleed or a brain bleed, and if it is not post-op setting, thrombolizing. Sometimes there are some clinical scenario where there is no hypotension. There are some situations where the clot burden is very high, more than 50%. Then we can have a consensus with a cardiologist and take a consent and thrombolize him. After thrombolizing, you do analysis, you maintain the perfusions, take in ICU, and then you anticoagulant. You can still save a lot of patients. But if it is an unexplained cause, it can be, most of the causes of pulmonary embolisms are too high. They are undetected. So post-op, that's why we have a DVT prophylaxis in the third day of a medical cases, and the post-op, post-surgery and all. Sometimes I had a patient of hemoptysis. Morning I did a bronchoscopy. I asked him to lie down right lateral side. The patient just listened to me. So most of the patient doesn't listen. Right lateral means till 1 o'clock, I wanted to come back and see at 1 o'clock, he did right lateral side without moving. He developed the DVT. At 1 o'clock, I asked the vascular surgeon. By 3 o'clock, he had an arrest. P. It can happen. DVTs are common. If there is a DVT prophylaxis, good tool. It is a good clinical practice in hospital management. Out of the hospital also, if there is a cast in the leg, People have died. Young patients, a doctor have also come with a pulmonary embolism. We need to say about immobilization, all those things. Pulmonary embolism in a CPR setting, we need to take a decisions firmly along with the cardiologist, create a consensus, intubate. Sometimes we can't save, it can go up to arrest, and they may require a ECMO or this thing. You really know the cause, and patient is young. You can maintain him, perfuse him, take a time for thrombolyze to act well.
Right, very, very well answered. So now, definitely these are difficult cases of pulmonary embolism, be they diagnosed or they are undiagnosed. But Dr. Johnson, I would like to bring you in with a situation which we see relatively commonly. That is, we have a case of tachycardia. We can feel the pulse, but tachycardia is there. Patient develops a sudden cardiac arrest. So, how will you manage that case?
So if you take a tachycardia with a pulsar, we have to see whether the patient is having a mentation, whether he is able to maintain the blood pressure, and whether it is having a supraventricular tachycardia or a ventricular tachycardia. If the mentation is there, if the blood pressure is there, he is having a supraventricular tachycardia, we can try a vagal maneuver and see. And if he is not going to respond to that, we can put him on one dose of adenosine and we can see. And if he is not conscious, if blood pressure is low, even if it's a supraventricular tachycardia, we have to provide him one dose of adenosine. And if he's not going to respond to that, he has to give cardioversion. In ventricular tachycardia, preferably we have to go for synchronized cardioversion at the earliest.
Right. So basically, the thing is that if rhythm is there, you cardiovert it, and that helps save that patient. But suppose the reverse thing happens. Dr. Pawan ko, I am giving the most difficult of cases, bradycardia with pulse. Sir. How will you manage that case if it develops a cardiac arrest? Sir, unmute.
Sorry. So symptomatic bradycardia can be pathological, and that the pulse, and it can be caused by structural lung disease, myocardial ischemia, hypoxia, and most of the time it is metabolic, like hypokalemia or the hyperkalemia, hypothermia, and it is also because of some medications like beta blocker. So we need to see the underlying cause of the bradycardia, right? And if the patient is really having the hemodynamic compromise, then we can give the atropine. Otherwise, firstly, we need to tackle the underlying cause, and if we treat the underlying cause, then bradycardia will resolve, right? The atropine can be given 0.5 to 1 mg in a 3 to 5 minutes, and maximum dose to be given is the 3 mg. But suppose if the bradycardia is unresponsive to the atropine, in that conditions, now we have the other alternative agents also, like the dopamine or vasopressin, which can be given, but they have a very limited efficacy as compared to the atropine. Now we have also the transcutaneous pacing. So whether to give the transcutaneous pacing or atropine or dopamine or vasopressin, it depends on the local expertise, clinical experience of the physicians, right? But if the patients, they have IV access available and they have the bradycardia which is unresponsive to anything, they have only one option left, and that is a transvenous pacing, until we have the facility for the permanent pacing. So the thing is that side by side we need to see for the underlying cause and treat it. And the ultimate answer is that permanent pacing, if we don't get any underlying cause and patient is having AV block or any structural lung disease causing bradycardia.
Right, very well told. So, as far
Ravi,
as
I would like to add one example to the to this, Dr. Ravi. I had a 95-year-old with black specs. He used to walk in my neighbor. He was staying. He had a syncope. He knows I have a clinic and all. He had a syncope and he came to me. The ER. Don't come to me. You go to the ER. Anta. He came to my clinic. You just go there. Anta. Then they did the for syncope, MRI, did the ECG, echo, everything was normal. He went back home again. Then he called syncope. Again, he wanted to come to the clinic. I just sent him back again. So he had a syncope because of complete heart block. He had a syncope because sometimes this just bradycardia is a syncope as a manifestation. He goes to the ER. So he had a complete heart block. That time the decision of doing a pacemaker is important. Bradycardias, these are the most common causes are this drug-induced bradycardias and the CHBs because of post-ischemic or non-ischemic. Sometimes we don't know.
And I think they are one of the most dramatic cases to manage. Really difficult if it happens in a We are all mentally unprepared at times when these sort of things happen. So you have to be very alert, very observant. And one another category, I know Dr. Hirennappa shares his beautiful clinic with his wife, who is a gynecologist. So Dr. Hirennappa is the best person to answer this. That suppose a pregnant lady develops a cardiac arrest, then what all to do? Any special care to be taken?
Pregnancy, we are not dealing with one, we are dealing with two. When you give an option to us, we need to save both. Even the guidelines says that people will concentrate, but when the priority is given for a child, if they have a first child, they are young. So husband and all relatives, I want the mother back. Forget about the child. Medical legally, we need to save them. Okay. So if it is the first is the priority of any other cardiac arrest, it depends on the age, means months or weeks of pregnancy. As the weeks of pregnancy progresses, the diaphragm will be pushing above, and the cardiac, there are a lot of other things which are going on. So we need to respect that physiology, and we need to adapt to that. So first thing is when the later stages of pregnancy. So when we do a ROSC to get that circulation back, the uterus is so big and it sits on aorta cable and compresses, and the venous return happens, and we can still have hypotensions and perfusions may not happen. So that continuous lateral displacement of this uterus, so that perfusion happens, somebody has to concentrate not above the diaphragm, below the diaphragm. Okay, so doing that CPR, that's good, doing that. But whenever there is a situation in any pregnancy, if the womb is the best incubator in the world, if the child can come out, we can survive the child, a new life, new beginning which is going to come. So if you are ultimately have a induce and get the baby out, you can deal with the mother later. So that happens, most of the patients, child is born and the mother has died. We have seen that happening. So maternal mortality is very high, especially in pulmonary embolism, amniotic fluid embolism. All these things are postpartum hemorrhage and other things. So if these things are taken care, so getting the baby by just delivering it, sometimes they can go for emergency cesarean section, peripartum, that these are important. Saving the child is important. So if not, in the ER only people have delivered. In the COVID status also, we thought it was admitted under me as a pregnancy, and all COVID, even if it's pregnancy, the pulmonologist was he was a cardiologist, he was a neurologist, he was a delivery. So ultimately, by the time the gynecologist, the baby, mother nature, the baby has come out on its own, only sisters have delivered. So it happens when there is an arrest kind of situations, you need to get the baby out. So baby, there are monitoring of the baby. And if you have an in-house team of neonatologists and obstetricians, take their help. They may not give an idea of managing a high-end intensive care. They know if the baby is out, they can manage in the neonatologist. That will be taken care, and they will be relieved of managing the adult as per the protocol. And there are certain things of doing a CPR, respect, and the way the physiology is there, and we need to adopt to that kind of effective CPR strategies.
Right. And one more thing is that, like Dr. Amal Johnson told in his talk about 5 H's and 5 T's, even you had mentioned. So I think we have to be very careful in pregnant ladies to watch out for these 5 H's and 5 T's. We might get one reversible cause, and even that may contribute to improving the mortality rate. Means we might actually save the patient. But then after pregnancy, another important change that has come over the past 4 years is that COVID came along. And a lot of our practices changed. So I know Dr. Subodh sir used to be the in charge of one of the most busiest COVID ICUs in town. So whom better than to ask Dr. Subodh, ki COVID ARDS patient is prone and suddenly there is sudden cardiac arrest. क्या करेंगे सर?
Ravi sir, you remember a big religious leader we cannot name, Obis Babaji. He arrested in prone position. Well, eventually when you are doing a CPR, what you are trying to do is you are trying to compress the left ventricle between two hard structures, sternum and vertebral column. So you can do it this way or you can do it this way. It's all the same. Yeah, the hand position will be different. So what you have to do is, if you are dealing with a prone patient and you have to do CPR, you have to put your hands at around T7 to T10. How to locate it? Inferior angle of scapula. So just a little below the inferior angle of scapula, you put your hands and you start CPR. First 2 minutes you do that, because if you want to supine the patient, it will take like 5 people and a coordinated effort. That will take some time. So till then, start the CPR in prone position, keep going, then call for people, arrange like 4 or 5 people, then turn the patient and watch for tubes and lines and everything. It is very difficult to do a prone CPR. But yeah, it can be done if we have trained people.
And one major change which came post-COVID was the very, they say a lot about mouth-to-mouth resuscitation in CPR. But COVID, the mouth-to-mouth resuscitation almost पूरा ही बंद हो गया, मास्क पहन के का इंडिकेशन आ गया. Now a big call out to Dr. Sukhram sir. मैंने आपसे बहुत देर से पूछा नहीं, but क्या करूँ, हम फिजिशियन से यार, अब सर्जन को CPR में बहुत लिमिटेड रोल हम देते हैं. Although I have some very important queries to ask from Dr. Sukhram is, sir, there is this thing we hear about, which is open cardiac massage. What is this open cardiac massage, sir?
Sir, basically till 1960, the cardiac massage CPR used to be more commonly being used in the open, with the opening of chest and doing the CPR. Because that time all these quality CPR was not available there. There was no guideline, no drugs, nothing was available. So the only thing was available, people used to feel it, they compress from outside. It is not being delivered effectively. So what to do? Just open the chest and go in and do the CPR. So this was the time when in 1960s, but later the guidelines came, the effective CPR training happens and all those things came. So this has been abandoned. Now this open cardiac massage is done in like ongoing surgery, chest surgery is going on and intraoperative, the heart has arrested. So we may have to do it in those cases where we have to take the extreme care, because putting one hand posteriorly and one hand anteriorly to the heart and doing this CPR, but we have to ensure it we should not injure the coronary arteries and coronary vessels, because these are the things which, if we injure them, we are totally damaging the heart muscles, and then even the heart will return back, but it will not work like the way we want to work. So with the effective care, with the proper handling, the CPR can be given. So one indication is that. The other indication is that where the chest wall abnormality is there and we are not able to do the normal CPR. So in those cases, but that is very extreme rare scenario with the surgeon team standby who can effectively open the chest within 5 minutes with the use of whether it's a median sternotomy or doing the clamshell or opening both the chest and simultaneously and doing the CPR. So those possibilities are there where people can do this thing. But commonly, because surgeon is doing surgery and intraoperatively it arrested, so nowadays it is only restricted to these situations where the surgeon himself is doing the CPR in the operative field.
Sir, I remember there were these two spoon-like things which you used to catch the heart and then give shocks. That is still in use, or now that is obsolete?
No, it is still in use, but it's very rare. Intraoperative defibrillation is there. We use sometimes when the heart goes into the ventricular tachycardia or AF or something which is not being diverted with the drugs. So in those situations we use it. Okay. But it is very extremely rare because drugs are very effective nowadays.
Very effective.
So surgeons are being replaced by the drugs and the intelligent people.
Right. Now, day before yesterday, I called up Dr. Sukhram and assistant told कि यार sir is busy, वो तो eCPR दे रहे हैं. Sir, ये eCPR क्या देते हो आप लोग यार?
Sir, eCPR is something where it's a very rare case scenario where eCPR is being used. So normally it's a conventional CPR. What we talk about the CPR being what we have talked till now. So eCPR means use of extracorporeal system into the ongoing CPR. So there is no validated guidelines are existing in the current system, but there are certain indications where the AHA said that if some patient who is outside hospital, witness arrest was there and brought to the hospital with the reversible cause, like something which is drug induced or something like that, and we were able to establish this low flow CPR. In those cases, the ECMO can be placed with the extremely efficient teams, and the survival chances are there. Though in these cases scenario, there is no randomized trial which is saying that, because randomized trial is not possible. in this case scenario, where they can say the ECMO has better extracorporeal circulation, has better survival than the conventional CPR. But yeah, it is being used in certain patients with the certain indications, and it is upcoming. So maybe we need more larger data to support this eCPR.
Right, right. Very, very.
Can I add,
Yeah.
Ravi? I had instances where we used this kind of big shot. I don't want to name the name. And they had all the things where a hospital can go and do all the blood test in their home and all. They never visited, did the TMT every year and all. They out of hospital arrest and cardiologist, a new cardiologist admitted, and they did the CPR and all. So, and he has an insurance about 1 crore or 2 crore or 10 crore, I don't know. So in 24 hours, the amount of the bill came in 24 hours is 42 lakhs. And that time, ongoing CPR, and they have put him on ECMO. They want to try all out, and ultimately the patient didn't survive. There was so much pressure on the cardiologist to write all the documentations and getting that insurance come. It took almost a month or 15 days for that, and doing that CPR for 24 hours ECMO and the CPR. Patients who can afford and who is a big shot, and they really push you to the maximum. That time the hospital management, everyone was coming into a picture. This kind of situation of CPR and putting a ECMO like Jayalalitha, they did like that. This kind of the only rare scenario where the push from the patient size is too high, then only we go. And if he is a young patient, in our system where they are self-paying, we normally don't get into this. It requires lots of hard-earned counseling and other things as a backup in these kind of patients.
Yeah, I fully agree with you. Means, when you work in some setups, when the CPR crosses half an hour, you actually are at times also made to be aware of the financial limitations that the family has in a very common situation. Because we are actually, everybody wants to save the life, but it is a practical world. So I agree with what Dr. Hirennappa sir has told, and thanks to Dr. Sukhram for telling us about this new technique of CPR, which is upcoming. Now, the newest kid in town can be only explained by my dear senior Dr. Subodh sir. Sir, artificial intelligence in CPR, has it found a place in CPR?
It hasn't, but it will find in next couple of years. Right now, maybe work might be going on, but it will definitely find its way in CPR. Because what is exactly AI? AI is basically a non-human working as a human. So let's say during COVID days, do you remember? Actually, I was managing this system of COVID कि किस hospital में कौन सा bed खाली और कौन सा patient कहाँ जाएगा. If there is a central database, then an AI can assign, this is the nearest this ambulance available, this is the nearest AED available, let's send a drone to that place. So an AI can watch over the whole system of a city, and they can assign resources accordingly, according to their discretion. That is one thing. What else it can do is कि maybe an AED within AI can actually judge the rhythm. That is already doing. It can maybe ask the bystanders to do certain things. Then maybe drones can be used. The drones can bring in the AED at time. The drone can be sent by an AI. The AI is controlling drones placed at certain places, and it can send it to certain places. That is one thing. Then they can have the real-time hospital capacity data, that this hospital has some place and we can send the patient there. So it can be done. The work of like 100 people can be done with a single AI-based machine. Dispatch decisions can be based on AI machines. Then what else can we do? Mechanical devices. It is doing CPR, it is getting feedback, it is deciding what to do next. Maybe increase the compression depth, maybe increase the ventilation. So yeah, AI will definitely have a role in CPR, and maybe within next 2 years only.
I am waiting for that.
Subodh, Dr. Ravi, this iPhone has that ECG monitoring, and they can connect to a defibrillator.
Yeah.
How is that effective, sir? How is that effective? No, I am not a cardiologist.
At least rhythm-wise, it is good. Only rhythm it can judge.
And we can connect to a defibrillator. It can inform them or a nearest center.
At least it can send an information to some hospital
emergency
or
system.
Your physician or somebody that this guy has had an arrhythmia.
Okay.
Like it can detect faults already. I mean, your Apple Watch.
It's not a foolproof method.
Yeah, but similarly, it can send arrhythmias to at least a center. Okay. That will work.
But Sir, like I told, I am waiting for that AI technology which will do the counseling of all the attenders in this particular situation. That is eagerly awaited. So now I think we have discussed quite extensively. There are one or two questions from the audience which we need to address. The vanishing lung, the question, sir, Dr. Jyoti has again re-messaged telling that she is referring to a big cyst or bulla in a patient with hypoxia and urosepsis. So she is really wanting some clarification on CPR in such a patient, sir.
Right. See, I don't know this vanishing lung syndrome. I just learned it right now, but I'll answer with simple logic. If somebody has a big bulla, and if you are planning to intubate him, you are going to give positive pressure ventilation, that bulla is going to rupture, the patient will end up in pneumothorax. So what you can do is intubation will be the same only, but maybe you can plan for lesser pressures. That is one thing. Secondly, what you can do is before intubation, you keep a chest tube ready, you keep needle decompression system ready, so that when you intubate and if the bulla ruptures, you can handle that situation. You can just prepare for what is coming.
Right. And one more very important question, which I think maybe we should ponder is that suppose any young person dies after CPR, is post-mortem mandatory in India? Is there anything like that which is going on?
No, I don't think so.
Dr. Sukhram or Dr. Hirennappa, Dr. Pawan?
Sir, it is unexplained in a ER, in an unexplained call. We have this thing, there are definitely guideline. Postmortem should be this. If you don't know the cause of the patient, you have a CPR done, a young patient, 28-year patient come. So they have some relatives who are distantly. Everyone wants to wash off the hand. The hospital wants to wash off the hand, and attenders, they just want to take the body without anything. But it is our bonded duty. If you are running a hospital management or hospital, you are a part of that. For a doctor, if you are not signing anywhere and you are not involved in the case, you are out of that equation. But if you don't know the cause, child has come. Sometimes a small hospitals try to push to the big hospital. The patient has arrived to the death, and they will send back the patient to this to get the death certificate. So it has to be documented. Somebody has to sign for it. So if you are running the hospitals, giving a police intimation, and police says that you have to push off, they are giving this, means they can't say it. You can actually report it to this thing, and a number of postmortems done in a young patients who don't know the unexplained task, poisoning and other things, we need to subject to postmortem, and that is mandatory as a legality for the hospital.
Sir, in cases where
it's not necessarily everyone is required. You have a COPD patients, cardiac arrest who has come a known cause, and people know about it. Patient was been coming to us regularly. They were told that CPR, see, 75-year-old. Book says that 75 to do the CPR like that. But we take our human brain is more intelligent than the AI and say that a 75-year-old who has been suffering here 2 times intubated, who has come back, we say, Dishan, don't intubate, man, is carbon dioxide, let him die peacefully, tender loving care, and take attenders in a confidence. No problem will happen.
Right.
In a young patient who comes.
Sir, in cases of MLC, it is our job is to inform the police. Now let the police take call whether postmortem should happen or not happen, because most of the hospital may not have the postmortem facilities.
Sir, what is the MLC? MLC, even if it is a poisoning, is an MLC, not only a trauma. So sometimes that unsuspected, if you have a suspicion, we need to intimate the police.
Yeah, our job is to inform the police and let the police decide whether they require to have the postmortem or not, because most hospitals may not have the postmortem facilities, because postmortem mostly we require to postmortem happen in the government hospital or the mortuary where it is being required.
If they don't want to name it and this thing, we should not have any hospital record. They should not have anything which is there.
Yeah. But one important thing is 50 people come with that CPR case, and then at least the ER should be standing after the.
It's true.
That is important. So, Subodh sir, please.
Hospital in Indore, very prominent hospital. Like one patient came arrested, practically brought dead, and like a team of attendants came. They held syringes. They picked up syringes from nearby. They held them to the necks of the residents, and they asked them to do CPR for like 45 minutes to a brought dead patient. So yeah, what you said, 50 attendants, that is the most important situation these days.
Right, sir. So now I think we have extensively discussed this topic, very important topic of CPCR. In Sweden, 100% of the population is CPCR educated. In India, we are just 2% educated. So I think collectively today, via the platform of CCI, we have contributed to educating at least 1498 people more about CPR. And at this end of the talk, I would just like a take home message from all of you. I would like to start with our young Turk, Dr. Amal Johnson. Please, what is your take home message?
So the thing is that basically, like what you told, everybody must learn the basic art of performing a proper CPR. So that is very important. Can be a bystander and provide an effective CPR, and we can basically save the patient.
Right. So now from Chennai, I go to Bangalore via the highway. Dr. Hirennappa, what is your take home message?
Sir, as we are young, initially we are enthusiastic. We are in ICU. We learn the techniques. We relearn, unlearn that. The ABC has become cab, so that we need to know. So hospitals, we are working in a high-end setup, so they have a ACLS and BCL code. For us also, it is important changing. The ER has taken a lead, and cardiologists are also taken a lead, and we have a nursing in charges, and all the system door to angio has been reduced. It's all important. Sometimes it might be your own family member. Things have been not the way it is transferred, the way you reach the hospital, the way you do it. If you do things according to the SOP, things can be saved. Don't worry about the result. Do your karma properly. Do your SOP. That's why guidelines teaches us. So a small little things, a small mistakes can screw the life of a patient. And a small precautions and doing certain things correctly can save a life in a young patient, especially. I'm not talking this thing. I have saved a lot of patients like that.
I remember. And now, Dr. Sukhram, please, your take-home message from the CPCR webinar.
Sir, most important thing is do proper CPR. And what is new, because we have all have to get updated with the new knowledge, what is upcoming and what are the things which we should all know. I'm not expecting people on the road to do the CPR, but I'm expecting we as doctors, the all medical, paramedical facilities should know that how to do a proper CPR and what is there in the emergency, wherein a small thing can help can save the life. So that is my take home message, because we in the most hospital, the most people may not be aware of the things, what is CPR and how to do it properly.
Very right. Dr. Pawan, please, your take home message for CPCR.
Besides very effective CPR, we need to have the underlying cause of the CPR in our mind while doing the CPR, because we need to have some incorporation of modification of the ACS and BLS guideline, like in obstructive airway disease or the pneumothorax or the pulmonary embolisms, so that we can have a more effective CPR when we are doing. So the underlying cause of the cardiac arrest should be in our mind while we are doing the CPR.
Right. Dr. Subodh, sir, please, your take-home message from CPCR.
Right, sir. So first of all, we should all master ACLS. We should know ACLS by heart. Fine. But ACLS is guideline. It's not gospel. So we should learn to modify ACLS according to special situations. Like few things are given in ACLS book, but our brains are way bigger than a 200-page book. So we should adapt our own learning along with ACLS, and we should modify it as and when the situation arises, rather than just following it by the book. That's it.
Very correctly said. And to summarize this whole thing up, whenever in the paper or in the news we hear that a CRPF personnel or a doctor on top of the plane in the airport, some anesthetist while himself being treated for COVID in an ICU saved another person's life while doing CPR in the ICU. We have heard so many golden stories about CPR being given and lives being saved. So this is one thing which is really associated with the godliness of the medical profession in the general public. So I think as medical specialists, we need to be updated, like Dr. Sukhram very correctly told, and as Dr. Subodh Chaturvedi sir told, that you have to apply yourself in different situations. like Dr. Hirennappa told and Dr. Pawan told, that we have to be specific and we have to be algorithmic. And like Dr. Amal very correctly told, that we should know CPR. Every bystander in India, if they know CPR, then we can very heavily come down on this sudden cardiac arrest mortality rate. So at the end, I would like to thank all of you for participating in this very important webinar. And I would like to thank CCI. I would like to thank all the audience, the technical team, which has cooperated excellently for making this happen. And I would like to wish all of you a very, very good night. Thank you.
Thank you very much, sir.
Thank you very much.